Thank you, everybody. Thank you, everybody who's joined us or will be joining us in the next few minutes. I'm super excited about the opportunity to speak with Beth Macy. I think all of you know Dopesick has like taken us all over, both, kind of excited us, warmed our hearts, and allowed us in Appalachia to see ourselves in a way I don't think that we've seen ourselves both on screen, but also in the written word. So we have a 2 p.m. start time. So I'm going to give us another minute to let some more folks join us. And then I'm going to introduce Beth. And what we're going to do is that, we're going to do this the way I like to say a Larry King way, not the Oprah way. Oprah always comes super prepared. Larry King comes knowing nothing, or he came knowing nothing. He's not with us anymore. So I'm going to be asking some questions. Some of them are going to be like, Beth might look at us like, hey, what is that for? But I want to get to know you. And so this is how I'm going to do it. I want to get to know you. I want to get to know about your process of writing this whole thing. And then we're going to talk about the opioid crisis. And we're going to talk about some of those questions that folks might have. We have people that are going to be joining us. I don't know if we have told you, but we have some super special guests that I'm excited about. We've got the Deputy Director of SAMHSA, Substance Abuse Mental Health Services Administration. My good friend Jim's going to join. And then we've got my other good friend, Dr. Christensen, who's with the West Virginia Department of Health and Human Resources. And we want to talk to them a bit about what their response has been and is to the opiate crisis in Appalachia, West Virginia specifically. So we're at the 2:01 mark, so I'm going to go ahead and get started. We want to introduce yourself and tell the people who you are and why we're talking to you today.
Me?
Yeah, you.
Okay. All right. Well, you asked me. My name is Beth Macy. I live in Roanoke, Virginia. I'm married to a school teacher, and Dopesick is my third book. Before I wrote books, I was a longtime newspaper reporter. I mostly worked for the Roanoke Times here, kind of on the outskirts of Appalachia. I worked there for 25 years off and on. And all three of my books have grown out of reporting that originated at the Roanoke Times. I was the Families Beat reporter, and I wrote largely about marginalized groups. And it hit me about 10 years into my career, back when my hair was still dark, that the stories I wrote best were the stories about outsiders and underdogs. And I think that's because I myself identify as an outsider and underdog. The writing, when I write about people I admire, when I write about people who are really like bringing it and have passion for their work, that's really when those two things intersect with my values, that's when I do my best writing. So I always say, like, I'm going to write about the opioid crisis. What moves me most about that? And I start with the stories I can find that move me the most. And then I just report them like hell. I just report and I report and I go back and I'm like a bad virus. I just keep coming back.
Let me ask you a couple questions though before we get all the way there to you getting to the writing part. So I have questions that I like to ask people. Where do you fall in the sibling order?
I'm the youngest. I'm fourth, and I was a midlife accident.
See, and so I always say that I always think the youngest are probably usually the most experimental, and there are many studies that show that the youngest actually have the highest IQ. My sister who's 8 years older than me won't believe that, but it's true. And so tell me about you as a kid. When you were a kid, did you know you were going to be a writer? What'd you want to be when you were a kid?
I just wanted to do well. I always wanted to do well. I'm from a family that had a lot of addiction going back some 4 generations. We were very poor. We were very kind of always on the edge of maybe getting our lights cut off. And I didn't want to have to struggle. And so I graduated from high school in 1982. I'm the first person in my family to go to college. And I'm not saying I'm smarter than my siblings. They just didn't have that opportunity. They're much older than me. And when I came of age, I was a good student. I wasn't like top in my class. I was National Honor Society and I was involved in a million things. But I say that going to college, and I went on full Pell Grants. I had 3 jobs, 3 work study jobs, Pell Grants, some small scholarships, but mostly it was need-based financial aid. The deal is I went like during some of the last years when a full Pell Grant paid the ticket, paid the full
Mhm.
ticket. It has long since stopped doing that. And that's why I think higher education is so important. I mean, I dare say that if I hadn't gone to college, I would maybe be like the people I write about in my books.
Mhm. Right.
I think
So,
it saved
and
my
that's
life.
one. Right. So that's, it's one of the things that, we talk about at community education group a lot is that, there's a difference in kind of what happens in Appalachia versus I think what happens sometimes in urban environments is that vocational education is also a key way out of poverty for a lot of folks here. You depict the work in the mines, I think in a way that many people don't, right? Is that it's hardworking people doing hard work. And I think that people don't always understand, or they want to judge the work of the miner, or they want to judge the mines. But the thing is, we have not necessarily come up with jobs that will replace the economics of that. Mining jobs paid well, and they paid well for generations. They were poor, they were hard on the body, they were hard on the mind, they were hard on the soul, and they were hard on the environment. But those jobs paid well. So, what did your parents do for a living? I mean, what was your parents' background?
My dad dropped out of school in the 7th grade. He was at the tail end of World War II. He was a cook. Um, we're, they were from Dayton, Ohio. My mom worked in factories, except for when the economy would tank, she would get laid off. And then she would do under the table work, like the people I wrote about in Factory Man, which is a book about globalization. She would babysit other people's kids or work waitress at restaurants badly, she said. And my grandmother lived next door. She owned our house. She literally kept a roof over our heads. And she was just this, she drove my mom crazy. She was her mother-in-law and she thought she was really nosy, but she was wonderful. She taught me how to read before I went to kindergarten.
Hmm.
She never didn't give me money for candy. Like she never said no to me. And there was just like having this one special person made a huge difference in my life.
Right. And people always say, well, why is she asking all these questions about background? Why is she asking all these questions about who's this? Because I think it's really important to understand who the person is that got those words to the page, and because I'm going to ask you some other questions, later on down this conversation, about like what's it like to work with Batman for the first time? Did you meet him? All of that kind of stuff. But I think that that's the work that we do, because if you look at the show, read the book, what you read on the page is you read passion, right? You read understanding and passion of a people and a culture that I don't think many people get. And one of the things that I when I saw the show and in the book, I got two things that I think that people really don't capture about this region is that I like to call it a malaise or haze that lays over Appalachia, West Virginia, Roanoke, Virginia. It's like when you drive in, it just seems like there's something heavy laying on it. It's a feeling, it's a look, it's a smell, it's a taste of the region. How did you capture that in your books and in the show? How did you make sure that they saw that and captured that? Because it's there, it's on the page, but you can see it in the show. Do you know what I'm talking about? The sense I'm talking
Yeah, yeah. I mean, my first job, I was the first paper girl in my little town. I delivered newspapers after school, and I learned how to talk to all kinds of people. And so my books really are just as good as like the people that are telling me things. And when I can build trust with somebody, and I don't hit it off with everybody, but I hit it off with a lot.
about?
And my goal is to try to get people to open up to me, not to make everything seem great or hunky dory, but to really help me experience what their life is like. And so I feel like, back to that line about doing my best work when I'm moved by somebody's story, when I'm really in there and somebody is opening this window to me, that's when that's when I think the stories pop.
Mm.
But it's all about trust. And sometimes it takes, I mean, my second book is a racial history. It took me 25 years to get the gatekeeper on that book to trust me enough to let me write a book about it.
What's that book about? Do you want tell people what that book's about?
Sure, it's called Truevine, and it's about the Jim Crow South. It takes place about an hour south of here. It's about uh, this woman who has two albino Black children. She is a sharecropper, and they are stolen by the circus, and they become exhibited as sideshow freaks. And it's about her efforts. Now, she can't read. It's 1927, and Ringling Brothers is coming to town, and she gets her sons back. I mean,
Mm.
it's a great story. But when I first set out to tell that story, one of the brothers was still alive. He was in his 90s, and he was taken care of by his great niece named Nancy Saunders. She ran a little soul food restaurant here called the Goody Shop. And the first time I went, I sauntered in there with my dark hair in my 20s, and I said, "Hey, I'm Beth Macy from the Roanoke Times. I understand you have this really interesting story." And she pointed to a sign on the wall that a customer had given me. And the sign said, "Sit down and shut up." And she meant it. Like, no, he's resting. He's retired. He's been ogled at and made fun of his entire life, and you're not going to get the story. So I just kept going back and hanging out, and I wanted her to know me, And she finally let me do the story for the paper after her Uncle Willie died. And then in 14, she let me write the book Truevine.
Mm-hmm. Wow. So, I mean, it sounds like, again, I mean, I think that I feel like you tell the story that the people don't want to tell, really, but the story that we need to know. And I think is that the reporter in you think, or is that just who you are?
Yeah, I don't think about it too much. It must just be who I am. I mean, I like to connect with people. I'm probably better talking to strangers than I am members of my own family. I just have always been like that.
Yeah.
And, goes back to being a paper girl and having to collect and think about all the things you have to do to collect. Nobody wants to pay you. They don't answer the door. And you kind of have to make people like you. And I don't know. I just find people endlessly fascinating. And when you add on the layer of trying to explain to America about itself and about the things that don't want to be seen, whether it's a woman in the Jim Crow South or what happens when half of a community's jobs go away and the rich people just get richer, or it's what happens with addiction. I know there are people that want those stories to be told. And so I want to find them to help other people understand. I mean, it just takes a little bit of work, but you don't have to scratch far to find these stories. And I think a lot of the stories in rural America, like the ones I've just written about, are largely overlooked by the legacy media, by big city papers. The legacy media has been destroyed in a lot of medium to smaller sized towns. There are towns with no newspapers, and I just think it's so important, because otherwise it just becomes like who won what football game in the news and who committed what crime, and it's not an accurate view of what's actually happening in our world. I think newspapers are so important.
Now, I mean, because I think that's the important thing is that, we are a community education group. This is so important to us because we're in the middle of this We Are Appalachia project of getting to folks to understand the heritage of Appalachia, the culture of Appalachia, the diversity of Appalachia. We think that people think that they know what the region is or who is in the region. And I say you don't know. I think you don't know the diversity of it, nor do you know the character of it. So, I guess, can you talk to me a bit about kind of the I guess the trajectory of the books that you've written? Is there because Factory Man, I was on a call with our project officer from the Centers for Disease Control the other day, and he said that was the book that made him weep about you. It wasn't Dopesick. He said it was this Factory Man book. That's when he fell in love with you, is what he said. And so can you talk to me about the kind of each one, like what got you to each one?
Yeah. So Factory Man, it's told through the perspective of this one furniture maker who doesn't, as he called it, went cheap with the other woman down the street. You know, he didn't close his factory and have it made in China because it was cheaper. In fact, he sued China or petitioned the government to investigate China for illegally selling product in American markets with the goal of putting us out of business. And it put, 350,000 furniture workers out of business. And like, who sues China in a court of international trade from Galax, Virginia? Only somebody with such a super huge presence. And so I was fascinated by him. His name is John Bassett III. And that book, because it just made the hair stand up on the back of my neck immediately when I met him, because he was this badass, could tell a story like nobody's business, could, had all this chutzpah. Also, his family legacy, being from Bassett Furniture originally, was super interesting. You could tell the whole history of the industrial South through his family. Oh, and by the way, he had a big break with his family in 1982. And so it was a juicy family feud story too. And that combined with what is always the heart of it for me is the little people getting left behind. All those people who lost their jobs, which were not unlike my mother when she would lose her job. In fact, I remember one of the first interviews I did with a displaced factory worker. She gave me her number at the end. I always asked, like, if I had questions, how can I contact you? And she said, well, here's my mama's number because my phone might get turned off. And that just, I got kind of goosebumpy just telling you that, because I remember those feelings as a kid. And when I can write about things that raise those kind of feelings with me, I know I'm doing what I'm supposed to be doing.
Right.
So the Truevine story, that also grew out of a newspaper feature. I just fell in love with Nancy, this character who ran this restaurant. I never got to meet Uncle Willie, but she and I go back a long way, and I love her. And then Dopesick grew out of some reporting I did back in 2012. The thing on everybody's mind was, I normally wrote about marginalized communities in the city.
Mm-hmm.
But everybody was talking about, because it made front page news, the fact that there was this growing cell of wealthy white kids using heroin in the suburbs. And it made news because one died of an overdose and the other was about to go to federal prison for his role in selling him the heroin. Now, they were both user dealers together, right? But one died, the other goes to prison. And I wrote this 3-part series, and readers sort of like spit up their coffee. What? Wealthy white kids are doing heroin? We had no idea. And so I wrote this series, and then I actually pitched to do a book about heroin after Factory Man, and I couldn't get the attention of anybody in New York because they're like, heroin? There's not a heroin epidemic. Like, they didn't know. They said Roanoke was just late getting it.
Right. So that's one. So before we kind of really launch, because I'm going to go, down this whole road, and one of the things that we don't talk about a lot in this country, or I'll say we don't talk about enough, is the way we have both portrayed and responded to the opiate crisis for rural whites and for white folk, and the way we responded to the crack epidemic in this country. We had very negative portrayals of women in particular in response to crack. It was, crack babies instead of saying, and we didn't really have any conversation about the number of babies that were born opiate addicted in this country. You didn't see it in the media. It wasn't, but we had many of the neonatal NICU units throughout this country were overflowing. What kind of is your experience with or thinking about the difference in which the two responses in this country were framed?
Yeah, I mean, absolutely. And it was a crime that that story was covered through a war on drugs lens. We're trying to kind of unravel this war on drugs now, and the bricks from the wall are falling on our heads. We're not doing very good at that either. But absolutely, I mean, a lot of experts will say that things like not Black people were immune from the opioid crisis originally, but the fact there was data showing that doctors, by and large, didn't prescribe opioids to African Americans because they didn't trust them to responsibly use the medications. Now, we know now that with fentanyl being responsible for most of the opioid deaths right now, that the rate is going up faster among Black Americans than white at the moment. We've still lost more white Americans to the opioid crisis. But I'm hopeful that with the attention that the overdose crisis in general is getting, that this will get to some of those endemic issues going back to 1914 when we outlawed heroin as a way to punish Black people during the Jim Crow era, and to say these drugs are bad, these drugs are good. And so you see that, coming straight up through, Nixon and the whole Southern strategy of let's punish the Black people and incarcerate them for drug use, because we can't say that out loud, but that's basically what's happening. And I talk about that a lot in my next book, which comes out in August. It's called Raising Lazarus. I have a chapter on the drug war, which a chapter doesn't do the drug war justice, but we know there are some great books out there that go into much more depth. But I'm trying to draw a line between the people I met, who I'm reporting from, who are in jails all over. Many of them started out with OxyContin. And many of them are in there for probation violation, Black and white. And it's the poor people and the people of color who are paying.
Right. And so we have a couple of comments that are coming into the chat. And one of the comments is from I'm gonna use his name, it's Greg. I'll just use his first name, Greg. And what he says is that he says slowly we're losing Appalachian heritage due to substance use addiction issues, which we're seeing in our area. He said, what would your recommendation be on how to tell this narrative through perhaps an arts or cultural perspective to our political leaders on a local or state levels? It's the question is, how do we tell this tale? We're meeting CEG right now. Like I said earlier, is that we've got what we're calling our We Are Appalachia project. And we're talking about it. Dr. Noel Chaddock, who's joined our team from Bates College. She's our cultural and ethnic heritage director. And what we do now is that we've realized that if we look at the literature, when we talk about Appalachia, that the idea of culture stopped being talked about 15 years ago. And what it pivoted to a conversation about race. So when we're meeting with members of Congress, what we try to talk to them about, we want a cultural heritage designation for Appalachia. There's a cultural heritage designation for the Appalachia Trail. There's a cultural heritage designation for many other, there's a forestry designation and this designation, but there's not actually a cultural heritage designation for Appalachia. And then one of the reasons that we frame it this way is so that we're able to talk about the opioid crisis. We're able to talk about HIV, hepatitis, workforce development, and all of the things that we think kind of are leading. I like to say that it's like a train, and that the engine of the train is substance use, and the second car is hepatitis C, and the next car is hepatitis B, A, and D. And then we've got lack of educational attainment, lack of workforce opportunity. We've got behavioral health challenges. We've got environmental issues. And I say the caboose of that car is HIV often. And what we've got to do is be marching down two tracks. We've got to figure out how we're going to address these issues and how we're going to get folks to pay attention and resource these issues. And I think that one of the reasons that we wanted to talk to you about this book is that I feel like this book kind of spells it all out. That no one, number one, no one's immune to the impact of the opiate crisis, but that we are still in the midst of this spin. This is not over. And that
Oh, it's worse than ever.
Right. And you add a syndemic, which is HIV, Hep C, and substance use on top of COVID. And we see a region of the country that is in desperate need of support. So I think that when I look at Greg's question, it's how would you say, we're trying to get a cultural heritage designation. We're meeting with members of Congress. We're meeting with the White House. Samson's coming on. We're saying everybody really needs to kind of put in an effort. What would you tell the people? What's your recommendation of what we need to do?
Well, one of the things, and it's a model I love, I did a piece about an artist out of Kentucky named Robert Gipe for Oxford American magazine. If you could just Google my name and Oxford American, it should pop right up. What he did, he worked at a community college. He's a novelist. He started engaging his students, who were community college students, to go around and interview people about the opioid crisis. And they would interview their relatives and, all kinds of people. And then they started putting plays. It was called Higher Ground. They've done a series of 5 or 6, maybe more than that. The most recent one that I saw was called Needleworks. And they went out and they did all this oral history collecting around the idea of needle exchange. And it wasn't what the science says was the best. I mean, people were pissed off about needles, right? One girl told a story about, I borrowed my mama's jacket and I put my hand in the pocket and I got a needle stick with a dirty needle. There was a lot of anger about it. And so they took all these stories, they wrote it into a play, and at the end, it was like a call to action to the community. And that was all the people who were there watching the play. I saw it in Virginia, but they went on the road and they used it as a tool to try to talk communities into opening needle exchanges. And I just think that it celebrated the heritage. It had these wonderful details. It had humor. It had heartbreak. And buddy, let me tell you, some of the actors and actresses were people in recovery, or people who work with people in recovery. And those tears on the stage coming from them were real. It was one of the most moving things I've ever seen. And I think anytime you listen to the voice of drug users and family members, because this impacts all people. All across America, we now have a third of families say substance use disorder is a serious problem in their family. And I dare say the numbers are higher than that in Appalachia. So I think anytime we can start to get the voices out, the stories out, that really helps connect people and it helps build empathy to beyond just the knee-jerk, why would we give needles to users? Like, why would, that whole thing.
Right. So, one of the things that's happened last year is that West Virginia passed what I think is one of the most arcane harm reduction laws in the nation. So I think we've gone from 18 needle exchange sites to about 8 right now. So I think that we are going to probably spend the next year or decade figuring out what that response did. And I think we're going to have to evaluate it and figure out new programs and how we get folks to engage. And I just got a note here from Angie Gray. And she says what I think is one of the most important things. We have to stop blaming people with addiction. We have to stop blaming folks and that saying that this is, that this is always something that you can control. I think that while I believe that there was a very different response to African Americans and crack than we're seeing with the opiate crisis, I think we've got to do both. We've got to go back and do the repair of the images and the damage that we did around our response to crack. I think both in our institutions, jails, and others, but also we've got to figure out what we're going to do to support people who need our help. And it's a large infrastructure change. It's structural changes that we need to put in place. Now, I'm going to pivot here a bit for a second. And like I said, this is very Larry King-ish. Go ahead. You had a call. You're going to say something. Go for it. This is a conversation.
No, I was going to say shout out to Angie Gray, who is doing amazing work in Martinsburg, West Virginia. And one of the things I learned from Angie Gray that really helped me frame my forthcoming book, Raising Lazarus, is she told this little story, in a course of the hour or two that we've spent on the phone, maybe 3. She told this story about trying to win over law enforcement for needle exchange. And the simple act of her department raised the money to hand out the Narcan to the police officers who didn't want to do it. And she remembered how surprised they were. And it was that idea of building baby steps, like, oh, you care about us as people too. And so this idea, I mean, a lot of people think like you can't deal within the war on drugs, so let's go around it. Let's go around all the systems. But I don't think I think we're going to get farther if we meet people, if we meet both sides where they are. And that's a controversial thing to say in some harm reduction quarters. But I think about what Angie said about how when they came up with the funding to give the police in her community Narcan, how then they were more willing to use it. And, the same could be said with other harm reduction supplies. In the new book, I follow a harm reduction group out of North Carolina called Olive Branch Ministries, the nation's first queer-founded, biracial, faith-based harm reduction group.
Wow.
Say that 5 times real fast. And these are the coolest women. They started out giving out needles, posing as a food pantry out of the back of the pickup truck, and they would tuck in needles into like needles fit really good into a granola box of granola bars. And, they slowly made inroads with the law enforcement. And you could say, yeah, it should happen faster than that. But now you got a lot of communities still struggling to get law enforcement on board. And these women have gone way beyond that. They've got 3 needle exchanges. It's needs-based. They're doing low barrier MAT. They'll send out a nurse practitioner to a dumpster next to a McDonald's to get somebody hooked up with a low-cost MAT. So we've got to start making those little baby steps so we can get to those inroads.
Yeah. It's like, I think it's the National Harm Reduction Coalition. They started out with ACT UP doing needle exchange with baby carriages, right? So you put the syringes in the baby carriage, and this was, I think, in the early 80s was how they started out. So I think that's it, figuring out new strategies or any strategy that is going to work to increase access to the service. And I'm glad to see you gave a big shout out to Angie Gray. So now she owes me dinner or something.
I love me some Angie Gray.
I love me some Angie Gray too. That's if people don't know, Angie is a nurse at the I think Jefferson County Department of Health in the Eastern Panhandle in West Virginia, and runs a needle exchange, I think, in Morgan County, Jefferson County, and Berkeley County. And I think, people like Angie don't get necessarily all of the, I'm going to say, accolades and support that she honestly honors, that she deserves. Dr. Reedy, Dr. Ditton, who was up there for a while, and Dr. Ditton, who's now at the West Virginia Department of Health. He works with Dr. Christensen, who's going to come on later. But people are doing, as you said, just Berkeley and Morgan. I gave you Jefferson too. I'll give you all the state if you want. But I think that there are folks out there that are doing the work in government. And I always tell people that sometimes we think that government doesn't care, or government's not engaged, or government doesn't worry about us. But there are some really good and strong people in government at the federal level and at the state and county level. So I always think that we should thank them and honor them where we can. Now, like I said, I was getting ready to say, now I'm going to really make a hard pivot. And you're going to be like, what? So tell me what it was like when you got the contract that said that you were going to make a TV show.
Well,
how'd that happen?
I wish you would have been like that. So I have a literary agent, and I had the first 2 books have been optioned. Like Tom Hanks's people bought Factory Man, but it never got made. Truevine was optioned.
Tell people what that all means, because
option is like they pay you a little bit to like dib it. Like I got dibs, then I'm gonna first they hire somebody to write the script. Like there's a great script for Factory Man, and then they try to get somebody to make it, and that's the big sell. And then you actually do get paid when they make it. But so it's like lawyers get involved, TV agents get involved. And what happened with Dopesick is that there was actually a bidding war before it came out. And I picked the team that I met with. I just went with my gut. And I went with Warren Littlefield, who I think he has a photographic memory. He was like reciting lines from my own book back to me. I mean, maybe that was flattering my ego. But anyways, what ended up happening is I got paired with this showrunner named Danny Strong, who
What's a showrunner?
Showrunner runs the whole thing. Like there's 4 different directors in Dopesick, and he's behind them at every angle. Now he also runs the writer's room. So every word in the show has been touched by him. Every angle has been touched by him. They brought us together because Fox 21 had an opioid project, and Fox 20th, like they weren't talking to each other. And they had us meet in the middle. We met in Chicago one stormy weekend to see if we would get along. And, we were both a little like of each other. Like we both wanted our own projects, but they put us together and like we played really nice. And I had a really good experience. I went out to LA. I was supposed to live there for 5 months, work in this collaborative way, outlining the story in great detail with 4 seasoned screenwriters. And then COVID happened, so I was only out there 10 days. So I came on back and we did the whole rest of it on Zoom.
Wow.
Yeah. And so I'm glad we had a chance to meet face to face first, because then we had a little bit of trust, we'd had lunches together and gone to get coffee with each other. And so then we were on Zoom, and I think it ended up going 6 months. And I was just really happy. Like here was my 2 goals going into it. One was like, I'm not going to be able to show my face in Appalachia if we stereotype. Like there's not going to be no snake handling in the show, right? There's not going to be anything that like, it has to be authentic, right? Mm-hmm. And you've heard the criticisms of Hillbilly Elegy. I didn't want to do that. The heroes in my book Dopesick, people like Art Van Zee, Dr. Art Van Zee, Sister Beth Davies. There's a hero at the end of the book named Steve Lloyd. The Michael Keaton character is partly based on his experience. Dr. Steve actually came into our writing room on Zoom and told us what it was like to, be shocked by patients, to have reps tell lies, and then to get addicted himself. At the height of his addiction, he faked an injury so he could have surgery so that he could get OxyContin. And now he's like a world-class addiction doctor. I was interviewing him this morning, in fact, again, for like the 15th time. But so that was really cool that I was listened to, we brought in Robert Geit, the guy I mentioned a bit ago that I profiled for the Oxford American, just to read the scripts for sensitivity. He gave ideas. There's anecdotes in the show that are directly from his mind. And then my main thing is I wanted people to leave the show with empathy. Like this thing was done to us as a nation. And it's complicated because it's a slow simmering story that begins in 1996, and nobody goes back and tallies up all the losses, all the machinations where they bought off the pain orgs. They hire, pain as a 5th vital sign, famous doctors. They pay them to say things like pseudo addiction that aren't real. All the things we wanted to dramatize, all the things that they did in order to show that this was done to us by capitalism run amok, lack of regulation, and with the hope that it would make people have empathy for folks with OUD.
And it's like one of the things I think I said when we first met to you was that I felt like you laid out you gave us the examination of our problem, the examination of how we got here. Like a doctor came in the room and said, this is what happened. Like when my doctor says, no, you really do need to lose 30 pounds, and this is what happened, right? That you said, no, this is where this started. This is how this happened. And what I get to is, because I know we're going to have some folks from SAMHSA and other places coming to us, but when we think about it, I'm going to pivot a bit to the Sacklers themselves, right? Where we are is that we had this big settlement, but now we've got a judge that said, wait a minute, no, because my understanding is that the Sacklers themselves actually didn't lose a dime. Their company was taken and the company was gone, but they kept their boats, they kept their houses, they kept their horses, they kept everything.
Yeah.
Now,
if this settlement goes through at the end of their paying $4.5 billion over 9 years, that's the agreement that they're at now. Now it's in appeal. But if they get back to that or something like it, they're going to be just as rich as they are now, if not richer, with investments and whatnot. They basically filed for bankruptcy in one of a handful of jurisdictions that allow a company to file bankruptcy and protect the owners. So it's like the company did all these crimes. They've been found guilty in 2007, again in 2020. But it's like it's this driverless car, right? Like somebody committed those crimes at the company. The family was very, very involved in all of it, as we show in the show and as it have been reported in multiple books, most recently Patrick Radden Keefe's Empire of Pain, which is fantastic. And now we're going to let them like skate by on this bankruptcy loophole. I mean, there's just so much work that needs to be done with the bankruptcy laws, with the revolving door at the FDA and the DEA. We need to get back to regulating.
right. So what would so tell the people and me. So you're Beth Macy. You've written this book. You know what these people did. What do you think that we should be doing to get at a resolution, right? So because that's the other question. The settlement will come. Likely the money will go to the states. It's not going to probably go to organizations or institutions or individuals. It's probably going to go to state governments. Some individuals may file a suit and get some cash, but they're not going to get a whole bunch of cash. I mean,
Yeah, the average victim payout is like $5,000. That's not even enough to pay for somebody's funeral.
Right.
So really, it needs to go to what the science says works best, and that is easy access MAT. That's the low-hanging fruit. Cuts mortality. MAT, medication-assisted treatment, medicines for opioid use disorder. That's buprenorphine, Suboxone, or methadone. And we're just not making those life-saving medications available to the scale that matches the crisis. We have an 88% treatment gap right now. That means that 12% in the last year of people with OUD didn't have access to treatment. And we know that they have better outcomes when they're on MAT, but there's a lot of stigma around it still. There's still that old abstinence-only bias that it's just treating an addiction with another drug, which it's just flat out wrong. Now, some people don't want to take MAT. Okay, but let's just make sure they have all options, right? Only like 8 to 10% of people get better from OUD with abstinence alone. And that's after several years. And in an era of this high strength fentanyl, people don't have several years. So this is really important.
Right. And so I think that it's like one of the things that we're working on again at Community Education Group is what is called overturning the OTP moratorium, the opioid treatment program moratorium here in West Virginia, where there are existing only 9 methadone licenses in the state. And I'm a believer that we need to have as many bullets in the chamber as we possibly can to fight this epidemic and this crisis in this nation and in the state in particular. So we're working really hard to do that. And I think, as a person who's been sober since prohibition, but, I think that there is that space where folks say, hey, I think my friend Josh might be on here, and he and I had this conversation very recently about whether or not individuals who are in recovery can also be on MAT. And what's that level of judgment that comes in, particularly in some of the 12-step rooms that say, well, this is an abstinence-based only program. And in my reality for me is that I think that I believe that what it is that keeps you right, sane, and whole, and not using an illicit substance is what you need to do. And that one of the things that we can't do is place that level of judgment on an individual. So you're going to take an individual who has been coming through addiction, lived experience addiction, and you're going to say, well, you can't come to a 12-step meeting because you're taking MAT. You can't get support because you're on MAT. You can't get
that's a license to die. That's just malpractice. That's somebody pretending they're a doctor when they're not, in my opinion. Right. I mean, I was just talking to Dr. Steve this morning about what's going on now. He's a rural doctor in Tennessee, and he just lost somebody. He was trying like hell. It was a young woman that he finally got the jail to give her MAT, and then they let her out on a Sunday morning at 5 a.m. and without her psych meds as well. And by the time he finally got it arranged, she had already overdosed and she died. And he said his whole staff is just like, they were in love with this young patient. And the reason that she went back to use is because she heard there was a warrant out for her from an old charge. And, we've just got to put humanity back in our institutions,
Right.
Like we say we can incarcerate our way out of this, but we're still acting like we can.
Right. So we have, like I said, we're going to have some guests coming in, and I hope that Brandon, who's our tech person, he just sent me a note saying that Dr. Jim from SAMHSA is here, and as well as Danny, who's a person with lived experience from West Virginia, to join us. For a couple of questions, et cetera. Except for, Brandon, we talked about a whole bunch of things of how I do stuff today, except you didn't tell me how I let people into the room. So you're going to have to, there we go. There he is. And there she is. Very good. Those are my people. So I want to introduce a couple of my good friends. Danny, can you talk a bit for us? And then Dr. I'm just going to call you Dr. Jim because that's how I know you. I'm going to let Danny go first, if you don't mind, Dr. Jim, and I'm going to pivot over to you. Danny, can you just talk about kind of like maybe what you want to talk about, or if you have a question directly for Beth, and what's it like going through the recovery experience in West Virginia? What is a good challenge? What was it like, and what are the challenges, and how are you doing today?
Well, first of all, thanks for having me here. I always love coming in and speaking and listening to you guys talk, because I can relate to a lot of things that have been said. Beth, thank you for the work that you do. I'm interested in some of your books, actually. And I have a hell of a story if you ever want to talk.
Absolutely.
As far as like being in West Virginia as a person with substance abuse disorder, when my journey started, it started out rough. I got locked up. I was looking at a drug delivery result and death charge. I did 6 months in jail. I got out on bond, and I went into my first treatment center, and I did a 28-day, and it was hard to get in there because I had been clean. So I was working with a social worker through the jail kiosk to get into treatment. So I finally got into one, and then I moved into a 90-day treatment, and then I went into a sober living home in West Virginia, and I was there for 19 months because I knew, like myself, 28 days ain't nothing. 90 days ain't nothing. So I kept continuing it because I was scared, because I know me more than anybody else knows me. And that you all were talking about, the 12-step meetings and stuff. I have been part of those. I've seen a lot of people come in and a lot of people not come back, and a lot of people lose their life because of the stereotype with MATs or, whatever kind of medication they're on. And a lot of people try to play doctor like you guys were saying, and it really is sad because people do lose their life. I've lost a lot of people that I care about. Myself, I've been Narcan, I can't tell you how many times. And when people start talking negative or act like they really know when they really don't know, like if you haven't lived it, then you don't know it. You can, I don't want to offend anybody, but like you can study all the amount of studying you want, but if you have not lived it, you really don't know. Like the lifestyle changes, even in like from my life in active addiction to my life in recovery, it's so much different. I lost my daughter for a little while. I got my daughter back. Um, I've been through a lot of stuff, but it's been very rewarding to find the recovery side of it. But it would be so easy for me to go back, because we all have those lifelong life terms, things that happen, you know. There's things that happened personally in my life that, the first thought that came up is, oh, I'm going to use. But with support and people that I have in my life, like I was able to get through that. But, relapse is also part of my story. I had 3.5 years clean of relapse. I found my girlfriend dead, and that really took a toll on me. And I struggle with that, and I still do struggle with that. Thank God, by the grace of God and a lot of work, I'm clean. But even like going through the sickness that comes with that is, I think a lot of people, if we didn't have that dope sickness, more people would be clean, because it's the worst thing to have to go through in the world. I'd rather be in labor than go through dope sickness. I'd rather have a toothache than go through that. And so some of those are the worst things you can deal with. It's just, it really is. It's really heartbreaking. Like just the things that people say. I think the best thing that we can do is educate. Educate, educate, educate. As far as harm reduction, I'm a firm believer in harm reduction. I helped the Light Project here in Morgantown for 3 years, and they have a great team of people. I know Angie Gray, she's a great woman. So like I am definitely a big harm reduction supporter. You know, everybody has a story,
right?
And
But
we
then,
all have it differently.
Danny, can you tell? But you're doing great stuff now. Tell about your job now. I mean, you have a great job. You're helping other people now too, which I think is a part of what we have to do to in our recovery is give back.
Oh yeah, like the last 4 years I've given back a lot, and it, and people in recovery, that's what we want to do. We if you look behind me, my whirlwind of tornadoes and destruction is still cleaning up. you know so like I try to give back. In the community, I've done community cleanups. I help people get into treatment. I go to homeless encampments and work with people that are experiencing homelessness, people that are with substance abuse disorder. Like I know, like I can relate with them more than others, and they trust because I have the lived experience and I know what it's like. So it's easier for me to like build the rapport with someone than just some stranger walking into a homeless camp saying, "What do you need?" Or walking up to somebody on the street like, "What do you need?" They're not gonna like really trust unless they know like what I've been through. Make sense?
Yeah, it does. And I think that was one of the things that I think one of my takeaways from Dopesick was that relapse is possible, right? I think so many times we see these shows or read a book or see it and say, well, you know what? If you do this thing, then nobody relapses. Everybody's just great. Life doesn't keep going on. But it's like I always say, life still continues to happen. I remember my first sponsor said to me once that, if you take a thief and you sober him up, you still just got a sober thief. You've got to do all of the other life work. And I think that's it, and I think that we all go through it, is that life and recovery, I think, are a path and a journey. It's not an event. And some people want to look at recovery as an event, and it's an ongoing process. So I wanted to, if you have any questions for Beth or you have any questions, I just wanted you to make sure that because I love you deep. And I wanted to make sure that you had an opportunity to share your story and then talk to Beth. And if you wanted to ask her something or whatever, and I just wanted to give you time to share.
Right. Well, I was the kind of person that was like, oh, relapse is not going to be part of my story. And it happened to be part of my story, and I put a lot of guilt and shame on myself over that because I went so long without it being part of my story, and then this traumatic thing happened in my life. Not that that's an excuse for me to use, but it was the tool that I had. I had other tools, but I threw that bag out. Like when in time of desperation and need, I threw the right tools out. If that makes sense.
Yeah.
But okay, Beth. So I want to help. What is it that myself or other people in recovery or even in active addiction can do to help with what you're doing?
Yeah, I think what you're doing, I mean, I didn't hear the title, but it sounds like you're doing peer recovery work. Is that correct?
Yes.
Yeah, so that is some of the most moving work that I've seen for my last several years of reporting. It's people like Brooke Parker, who is the Ryan White worker in Charleston, West Virginia, going out into these homeless encampments, taking people to methadone clinics. She's up at 4:30 every morning, giving people rides to treatment. She's connecting them to care. She's taking the guy who's in at the ER and he's been there for 18 hours, a sandwich from Wendy's, right? I'm thinking of another peer recovery person I know in North Carolina named Nicole. She chooses to work the front desk of the FQHC because she realizes that most people are so scared the first time they ask for help that what they really need is a kind face. That person that answers the front desk, who answers the phone, is so much more important than they even know they are. And just watching her navigate was like looking at art, the way she was helping people. Um, the same things with folks who are going out and meeting people where they are, whether it's at a McDonald's parking lot or it's in the little holler where they live, and they're treating them like people with a medical condition and not like something to throw away, not like a criminal. I mean, we've got to
Yeah.
get humanity back into our institutions. And I say this to physicians whenever I get a chance to talk to physicians or people in power. I say, look, if you know drug court judges, you can tell them the stories that I've just told you about of jail treatment programs that are working, of people like the Christopher Atwood Foundation up in Northern Virginia that like they meet people the moment they get out of jail, even at 5 a.m. on a Sunday, and they help get them to their next step, and then they get them connected to treatment. Because the biggest barrier is still that a lot of people don't think they want to stop using drugs, right? And we still think that that's the key. Well, there isn't one solid fix to all this. And so we've got to go to them where they are and meet them where they are. And that's a clean needle to begin with. That's a sandwich. That's a burger from Wendy's. That's whatever they need to make their life a little bit improved. And then once you can build the trust, and it sounds like, Danny, you're doing that every day. Once you can build the trust, it's like, well, now what can I do to help you? And I've heard so many stories of people who run needle exchanges who say, like, you know, I didn't think nobody had been able to help me before because I had always been treated like a leper whenever I had gone to the ER. Maybe they fixed my abscess, but then they handed me a sheet of AA meetings and that was it. And when doctors finally start to treat people um, like people who use drugs, like people with a medical condition, they start to see results, and they're not seeing the same people coming back into the ER, and then they get really excited about their work. So I'm always telling people, if you have that social capital in your community, if you can talk to that reluctant judge or that reluctant doctor who doesn't want those people in his waiting room, well, guess what? You've already got those people in your waiting room. And, maybe you didn't take a free trip from Purdue Pharma, like so many doctors, nurses, and pharmacists did, but you participated in the system that they basically bought off. And it's your job to try to help get those folks out of the situation. that we, by looking the other way, allowed to happen. So, and I try to do that in a nice way. Sometimes it's crickets and people don't want to hear it. Other times, a few months later, they do their own research. And then this happened at the ED here in Roanoke, where I am. They're now doing, they got all their doctors waivered. They're now doing buprenorphine in the ED. I mean, it's fantastic. Lives will be saved because people change their minds, and then we're willing to admit they changed their minds, and that's really cool to see that happen. And what you're doing, Danny, it's amazing.
Right. And so, Danny, I think one of the most important things, and I'm going to pivot to Dr. Jim now, is first of all, I want to say thank you. But I think one of the most important things I always want to say, and I think is a critical piece of what's the response, is to say this: I see you, I see you, I see you, I see you. And I think that that's a big part of it. Sometimes people want to walk by and not see. I see you. Thank you for joining us. Thank you for taking out some time out of your day to share your story with us and to speak with us. I love you. Thank you very much.
I love you too. Thank you.
All right. Dr. Jim, what's going on at the federal government? What's the federal response to the opioid crisis in this country, particularly in Appalachia? I know you're a rock star, so tell us what's going on.
Well, first of all, thank you, Toni. I'm not a rock star. I am a advocate who can try to help guide and move this needle. When I say move the needle, we know that, as it's already been mentioned, I have to say, first of all, I agree with everything that's been said already. I do think that there are many levers that the federal government is trying to pull. Education in terms of primary prevention, as well as within our medical professional communities for decreasing stigma, enhancing the workforce. Those are things that certainly we're working on. A couple things when it comes to direct overdose prevention. We know that medication-assisted treatment, medications for opioid use disorder, is one of the most effective ways. It's evidence-based treatment. So just to plug, since we last spoke, we've released our practice guidelines for buprenorphine, which have allowed practitioners to now apply for the waiver, but not have to submit a training requirement, because that was cited as a potential barrier. So now all they have to do is apply with their license, and as long as they treat 30 patients or less, they are not required to submit the training. That's one big plus. We've seen an uptick of about 6,000 practitioners, about 1,000 extra every month have now been waivered. So we've gotten over 100,000 providers in particular for that. We are working on several overdose prevention strategies. The flexibilities that we've seen during COVID that we've utilized for telemedicine, and particularly for rural communities within West Virginia, but across the nation, we are working to make those flexibilities permanent for extending methadone take-homes as well as telemedicine, so that we can put more people in touch with treatment. I think Beth's comment about almost 90% of individuals with substance use disorder are not in treatment. We know that our workforce needs to be enhanced. We're working with HRSA. We're trying to get enhanced incentives for practitioners to go into behavioral health. We know that we also have to integrate with primary care. What I would say is that patients who are seeking this treatment are often not seen in specialty treatment centers. So we have to interface with our primary care colleagues, get more of them waivered, get more of them screening, because it's accurate. They're already in the waiting room. And I just want to clarify, I see a question in the chat, 30 patients per year at any given time. You can rotate them in and out, but that's just the start. If you wanted to go above the 30 patient limit with buprenorphine, we still want you to get some training. But that incidental patient that a provider sees in that community, he or she doesn't have to move them to some other specialty treatment. They can begin treatment right away, because we know that treatment's important. When it comes to the criminal justice system and reentry in particular, We know the medication-assisted treatment is going to help in reducing overdoses, whether it be buprenorphine or, even naltrexone. And aside from all of that, I'm going to get off the soapbox in just a minute, but I have to make a plug in our harm reduction and peer recovery as well. We are going to be starting a peer recovery center of excellence. We've already gotten the funding for that. Anyone will be able to um, call up and actually speak to someone to get technical assistance for their facility and how to implement and what standards they may look for. In addition to that, our harm reduction policies, we now allow for federal funds to be used to purchase fentanyl test strips. Certainly naloxone and syringe support services have been mainstays. I do see that there's a question here from Beth. We have done a couple things to relieve some of that anxiety when it comes to telemedicine. What we have to do is work with the DOJ. We're working towards utilizing several mechanisms to ensure that what we have implemented will stay in place, among which I will also hat tip our Center for Medicare colleagues who have revised the physician payment schedule to allow for telemedicine to be utilized for the induction of buprenorphine. So we are expecting to make all of these flexibilities permanent. Well, we will tweak them a little bit because there are some things that probably we're being informed of that we need to certainly look at. But the gist of it is that the sky has not fallen when we put all of these flexibilities in place. So we're going to look at that evidence.
Hey, Jim, before you keep going, you know what I realized? I didn't tell people who you were. I just said that you were my good friend. I didn't say what your job was. And so people are probably like, who's this guy? And what's all the stuff that he's talking about? And I want people to understand that the stuff that you're talking about and your job is a really important one in our national response. Do you want to tell people who you are and what your job is? And I'm sorry I didn't do that.
Sure. First things first, I'm a human, and I am a member of my community and a loving father, dog owner. That's the first thing how I identify myself. More than that, and my kids may or may not agree with the loving part, but certainly I try. But I'm an addiction psychiatrist. I spent over a decade at Hopkins. I have also gained expertise at the Center for Addiction and Pregnancy there. So that's one of my areas of specialty. But I am currently serving as the Chief Medical Officer for SAMHSA, the Substance Abuse Mental Health Services Administration. And we are working with our federal partners, our state collaborators, as well as stakeholders, because we know that we can't do this legislating or writing regulations from Rockville. We have to know what's going on in the local jurisdictions. So we're working on extending these COVID flexibilities. We're working on harm reduction. We're working on patient privacy protections as well. I see another question here about federal treatment of syringes.
Federal payment, I meant to say, sorry.
Payment.
So that's an important, and I'm going to give you the nuanced dance first, that we're working on this. We can pay with federal funds for the products used to clean it, to sterilize, where the line has been drawn is the actual syringe itself, but all the supporting things, the HIV and hepatitis education, even in some cases the testing for infectious diseases, all can be all can be considered allowable expenses. It's the syringe itself that right now has been a sticking point. What I can say is we're looking at it. I can't speak more because I'm not necessarily in all of those rooms, but I know it is a priority just the same.
So Jim, let me ask you a question. And I think this is one of those things that people always want to know. How come? Why? Why can't we use federal money to pay for syringes? Why?
I think it's a remnant of an interpretation of the Controlled Substance Act, that if it's being used utilized for, as case, facilitating consumption of an illegal substance. That is still against federal law. That may or may not change with more enlightened thinking. And I think that right now there is some will to help move that along, but I can't get ahead of the administration in that regard either.
Right.
I do see there was some other questions, but now it's scrolled down. So,
So I think I'm gonna pop to a couple of them.
Okay.
One was whether or not why is it that it was a cap at 30 patients? That was one of the questions. Why not let doctors prescribe for as many patients as they could possibly serve? And then the other one, I think I have another question. Are the rumors true that naloxone will soon be OTC?
Okay. Well, allow me to address the second one first, because that's a little bit easier. The naloxone being designated as over the counter is an FDA decision. We do recognize that it is a useful tool, not just for overdose prevention, but also primary and secondary prevention. The idea that it's available within communities we do support. I think 46 states have what we call a standing prescription in all pharmacies, which means that anyone could technically go in and get it because the state medical authority has allowed for that to be dispensed without a technical prescription from a provider. Now, there still is a prescription in the sense that it's issued to a particular person, not like to a facility or to the general public, but a person actually has to go pick it up and it's dispensed in their name. So we probably have to move that needle a little bit further, but that's sort of where we are right now. I can't speak to what the FDA's plans are with regard to that, but I'm sure I can pass that question along to them.
I'd appreciate it. And Jim, and so for those of you who don't know, Jim is like probably one of the greatest people on follow up that I know. So when he says he'll ask the question, he will. And so the question is also on the why is there a cap at 30?
So this was a decision where we, and I say we, the royal we of the entire federal government, really we had gone into uncharted territory with regard to this particular medication and relaxing within the authorities we have. We're kind of tied to what's called the Data 2000 Act, which created this X waiver, where we have to go through a special registration. What we're allowed to do is change the authority in terms of what we think would be reasonable in terms of the training. This is sort of a look to see what happens when we get rid of the training for this subset of providers. What we certainly want to avoid are unintended consequences, creation of, let's say, pill mills, if there were, a bad actor or two. We don't believe that that's the case. And certainly at 30, that's not going to be the incentive. What we really wanted to do was reach those providers that said that the training was a barrier. So let's get rid of the training, see how many more people come on in, and we'll use that data to inform further decisions of whether we change the limit, whether Congress decides to change the X waiver completely.
Okay. So, hey, Danny, I've got Dr. Christensen. He's going to come in. I'm going to say goodbye to you for now. And then we're going to bring in Dr. Christensen. And I've got a couple of more questions for Jim. And Jim, I wanted to ask you a couple of questions about budget. I know that your office has really, in the congressional budget and other ways, has really put in some new resources. Can you talk about some of the new resources that you guys have put out on the street, particularly for organizations or to be able to respond to the crisis locally?
So the funding mechanisms that we have are through appropriation through Congress, and we dispense the money primarily to the states, who then distribute it out to the communities. We have essentially doubled our block grant and our block grant budget to the states that are hardest hit, we're talking about, multiples of millions of dollars for that, as well as our state opioid response. So I would say between both of them in the federal budget, in a good year prior to what the increase was, we were allocating probably close to $3 billion to the states. We've probably gotten closer to 6 at this point, given what we're trying to do is respond aggressively to the overdose crisis, as well as understand that we have to be proactive. This issue I see with Beth bringing up fentanyl, you know, it's really been a game changer when it comes to not only how potent it is, the street value that it has, and which makes it attractive for dealers to distribute, but also when it comes to the lethality, that it's been mixed with, stimulants. People who are opioid naive, who've never been exposed to opioids, would die with even a single exposure. So the question that I see is that that buprenorphine isn't working for some people who have high withdrawal scores. In in reality, that's true. The difference between methadone and buprenorphine is that buprenorphine is a partial agonist. It has a ceiling, which means over a certain dose, it no longer has the same physiological effect. There's no ceiling for methadone. That we do want to make methadone easier to access. A couple things that certainly we're proud of with mobile treatment. Now, although there is still the moratorium in your state, mobile treatment is now something that any OTP that currently exists can apply for, so that they can even use the funds that they receive to purchase the vehicle. To get to some of those places to expand methadone access, and of course, we'd like to see even further movement on this, but sometimes it takes longer than we like to move that. What I'd also comment on is that when we're talking about, hundreds of thousands or millions of people with substance use disorder, if we can move the needle even a percentage point or two, we're talking about saving 1 million lives. So I try to look at it from the whole population perspective, that let's decrease overdoses by 10%. We save 10,000 people just off the bat, without even blinking an eye. So I think a lot of the things we're doing, I'm hopeful we'll see an inflection point of overdoses coming back down.
Right. Well, I mean, I think that we're working here at Community Education Group to overturn the OTP moratorium in West Virginia. We think that we need as many, I think, options for people as we possibly can. And I think that we're catching traction this year in a way that we have not in the past. So we really hope, because I do too think that given the change in the FDA regulation, that you can make methadone mobile and portable is a game changer, particularly in rural communities, if you can do distribution through a mobile or portable unit. And we have one other question, and maybe all of you can kind of talk about this. Kath has asked a question about substance use disorder being a disability. Is that how we see it? Is that how it's characterized? Is that how it's framed? And so I want to have everybody, all three of you. I want to introduce Dr. Matthew Christensen. Dr. Christensen is with the West Virginia Department of Health and Human Resources, and he is becoming my good friend. He doesn't know it, but he's becoming my really good friend. Is in response. What's your official title? Because I always say Director of Behavioral Health, but I don't think that's
Director of the Office of Drug Control Policy.
Office of Drug Control Policy in West Virginia. So I think that it's the big question is, how do we think about this as a disability or not as a disability? Let's talk about it.
Yeah, I can jump in first there, and my background is in both primary care and addiction medicine, and have certainly seen a lot of people who are functionally disabled from their addiction. When we classify someone as disabled, it oftentimes conveys lots of other societal implications, with regards to workforce ability, with regards to their ability to perform other activities of daily living. And so, I think people with addiction can certainly go through periods. It's clearly a disease, and I think we would all agree that it meets the criteria of a disease, just as any other chronic health and brain disorder and chronic health condition do. There are certain periods of time of people's lives that they may meet the criteria of disability to the point of being unable to be employed because of their disease, and I think that's certainly important to emphasize. That being said, I have tens, if not hundreds, of acquaintances and friends and former patients who are in long-term recovery and who are active members of their community, and who would not consider themselves disabled at this point because of the cure that they've achieved from their or the rehabilitation that they've gotten from their disease of addiction. So I want to make sure that we're differentiating this idea of disability as a long-term impediment to either employment or self-care or care for others, in that it is not a life sentence in that context, that there is no out there, because lots of people have achieved that. That being said, for some people it is very, very difficult, and we should support them during that period of time as if they do need full employment.
I think a part of the question is that Kath is after here is that there are rules under the Americans with Disabilities Act. There are supports under with the Americans with Disabilities Act. Do you see, or do you think we could move people with lived experience under ADA, and they would be covered under those same legislative provisions?
Yeah, I mean, I would still go back to my qualified answer of yes on a patient at the patient determined level for a period of time. I think that I've seen miracles happen of people in long-term recovery that are able to contribute more and do more than I am throughout the course of the day and do very, very well. And so I want to make sure that we're not saying that that's necessarily a long-term solution, but it may help them get the services and the important protections that they need during their period of vulnerability.
Perfect. Dr. Jim, thoughts?
So I agree with Dr. Christensen on almost all the points. Recovery is not a straight line. There are going to be moments where a person is going to need assistance because their condition has worsened. The same way you might think of someone whose chronic condition for any other disorder has worsened, whether it be diabetes, hypertension, that if we look at this as a chronic disease, we have to at least accept that there are going to be moments where this disease process becomes very loud, becomes active. And during that time, those individuals need support. So I think that, if I take the position that all of us in this room have taken, that this is something that should be supported in terms of treatment and recovery, we have to be able to, in that moment where the disorder is loud, support that person. I think it does become a bit more political when we talk about once the person has, achieved remission, and the support may presumably not be needed as much. What should be the mechanisms that are implemented then, and what should be the safeguards to keep them supported so that they don't end up with a terrible relapse and then no support at that time? I don't have a good answer yet for that. I think, that's another conversation with some of our federal partners to see where we can stand in becoming more equitable for those individuals with substance use disorder, because this is about behavioral health equity, much different than and it shouldn't be, but much different than how we treat other medical conditions.
Beth?
I totally agree with both of you guys. I think the important thing is to remember that we get pretty hopeless about this. I counted up all the deaths since OxyContin came out in 1996, all the drug overdose deaths. Most of the data goes back to 99, but actually went back to 96, and we've lost over 1 million people now to drug overdose deaths. And when I asked the guy at University of Pittsburgh who gathers this data using CDC Wonder data, it's predicted to double by 2029. And so those are some pretty hopeless numbers. But I think if we can work on getting people access to all forms of treatment, especially low barrier care for folks who have been outside of our systems of care, we're going to start to be able to turn it around. And because if we don't, we're just going to have greater declining life expectancies. The data is really clear about that. And I go back to this quote that an addiction doctor in Massachusetts gave me. I've gone all over the country and I'm always looking for the magic wand answer. And of course there isn't one, right? But he says this is somebody who has an MAT practice, and his wife runs a homeless shelter out of the basement of his MAT practice. And he wears a cross. He's very, upfront about being religious. And he says, I go back to this quote from a Harvard doctor in 1926 who said, the secret to patient care is to care for the patient. And I think when we do that, we could start to see our policies become more patient-focused and more low barrier. We need walk-in clinics. We need places where people who have been ostracized and made to feel like crap at hospitals and in doctors' offices, we need places where they can go and get help for all their needs. I don't know how that fits into the disability question. I just know that there are people out there, like our friend that was on earlier, who are really doing this work, and we need to scale that up at a response to match the scale of the crisis.
Right. So, Dr. Christensen, you've joined us now, and we have only a few minutes. But I really want you to talk about, because since you've been here, you've really tried to put in place a robust response. So, tell us about the response in West Virginia, and how you're addressing which is an ongoing crisis, and you've had some legislative challenges that you also have to deal with now.
Sure. Thank you, Toni, and thank you for bringing this group together to discuss this issue. We really have been at the forefront of the addiction crisis here in West Virginia, but I also like to think that we've been at the forefront of the solution. We've really focused on addiction and the addiction crisis from multiple angles, from prevention all the way up through early screening, treatment, recovery, and reentry, in a way that I haven't seen other states mobilize around, in a way that we've really tried to preempt some of these overdose deaths. And unfortunately, we weren't as successful as we would have hoped. We did see a decline, as many other states did in 2018 and 2019. And then we saw that bump up in 2020, and then a subsequent bump up in 2021 with the increase in fentanyl availability. But we're really looking at this from many different angles. We've looked at new ways to get naloxone out. We have quite a few pilots for incentivizing co-prescription in the state through pharmacies, through other organizations.
Whoa. What's that mean? Hold up, Dr. Matt.
Sure. Co-prescription of naloxone is the prescription of naloxone along with an opioid medicine. So if someone's getting a short course of medication for after a knee surgery, for example, or if someone's on a chronic dose, a higher dose of medication, they would be, we want to make sure that the physician has the conversation with the patient, the pharmacist has the conversation with the patient, and it gets dispensed. We have updated our standing orders to allow for community distribution of naloxone. So it doesn't just have to go through physicians and pharmacies. It can go through community outreach organizations. We're looking at new models with regards to naloxone around that secondary distribution, so we can highlight existing networks of people who use drugs and say, can we get those individuals more naloxone to then give to their friends or give to others around them, that because they're going to be it's not going to be me that's going to give the naloxone to the person that's really going to need it. It's their friend who they also use with, or their partner. We've really collaborated well across state government, nonprofits, and other private health systems. We have some current ongoing collaborations with some fast food organizations to try to educate around, and as well as gas stations, and we're working on a program with libraries to try to educate on what substance use disorder looks like, how to ask the right questions, how to intervene early, how to get naloxone in the hands of people that you think need it. We're in the process of really looking at transforming our state payment for addiction, and from medication for opioid use disorder, medication-assisted treatment, treatment facilities, and peer recovery support specialists to make sure that we're not just paying for episodes of care, which are oftentimes they're easy to document and easy to submit your billing code for, but really paying for that long-term outcome of saying, what do we really want 6 months from now? We want, if someone goes to Matt Christensen, the MAT provider, we want him to deliver this person in long-term recovery, and we want our state dollars to go towards that person being in long-term recovery. And we have very specific goals and objectives to get that done here in our state. And when we do that, we're also looking at linking that system and the continuum of care so that an MAT provider, MOUD provider, does not exist by themselves. But I'm also linked to a crisis stabilization unit and a residential treatment program and a recovery residence. So if my patient is struggling, or say their partner gets out of prison and is still actively using, I can bump them up the level of care very, very easily. And I'm still incentivized. I'm not disincentivized to refer that patient somewhere else, but I can get that person through appropriate informed consent into the level of care they need to be in this umbrella of care service provision, and really engage that person at the level that they need, because there's no one level of care that's going to work for everybody, whether that's MOUD, whether that's residential, recovery residence, or abstinence-based treatment, but they all work for some people.
Right. So we're right at 3:30. If you guys could give me 5 minutes more, I have a couple of things I want to wrap up on. So, Dr. Christensen, I know that what we're seeing and particularly in West Virginia and Appalachia is that we're seeing this growing syndemic of HIV, viral hepatitis, and substance use. One of the things that I really think is that these MAT providers sit at the nexus of it. What are we doing to kind of mobilize those MAT providers to be able to provide more linkage, more direct service and care for persons impacted by HIV and Hep C? And then I'm going to come back to all of you. If you can all answer kind of that question of how you're seeing that syndemic, then I'm going to let everybody close out and say thank you for joining us today.
Sure. Yeah. And that's something that we are continuing to work on, and we're certainly not there yet, but we hope to lean on you all as well with some of your projects on helping us get some of that education out. I really think a collaborative project where we mimic and copy some of the successful efforts of pharmaceutical companies, for example. Let's go to doctors' offices. Let's buy them lunch. Let's say, these are the benefits. This is why you do it. Follow up with them again in 3 weeks. Give them some brochures, some handouts, some fancy checklists. Let's get this incorporated into their medical record system so that there are alerts that are pended every single time that someone comes in with a new diagnosis of opioid use disorder. Have you screened them for HIV? Are they still using? So that we have consistency in those care sets and those expectations around screening for HIV and hepatitis. We're also working with our quick response teams, who are the teams that go out and engage individuals, which we have in more than 35 counties now out of our 55 counties. They go out and engage individuals after an overdose and judge their propensity and their level of readiness to get into treatment. If they're not ready, we're going to be, we're not done. Actually, we have more work if they're not ready, because we need to be testing them for HIV on the spot, in my opinion,
right,
and hepatitis, and giving them naloxone and giving them a few doses for their friends. Right. So, and then following up with them in another week, just like that pesky pharmaceutical rep does so well at getting us to prescribe expensive medicine sometimes as doctors. So.
Well, this is the second time that you've mentioned that model. So we're going to come back to you and figure out with a concept note how we're going to implement that model and how we're going to pay for that model.
Let's make it happen.
All right, Dr. Jim, give us your takeaway, your wrap up, what we need to know.
So I agree that the syndemic is something that we will never reach our targets of 95% of individuals being virally suppressed, 95% of those who are positive in treatment, unless we address this crucial population. From SAMHSA's perspective, we do require reporting of all of the facilities, both OTPs as well as all substance use disorder treatment facilities, to report whether they perform the testing and referrals. We track that data, and quite frankly, our grants project officers and compliance officers ask each program, why didn't you do it if they didn't do it? So we haven't gotten as high of a performance rate as we like, but it's on our radar. So we're looking to move that up year over year. Ultimately, we hope to make this an accreditation standard. Once that's in place, that our accreditation bodies such as CARF and JACO, to name a few, begin to use it as an accreditation standard, I think then everyone comes in line.
Right. So I think because I remember last year we met with you, Dr. Jim, and I think that it was something like roughly only 30% of the MAT providers in West Virginia were reporting all the data that they were supposed to report on whether or not an individual had been screened for HIV or Hep C. Do I remember that right? Because I'm old, so I'm going
I
on.
think it
memory.
was a little higher than that.
Right.
I want to say that our colleagues in West Virginia now have probably are closer to that 50% mark. But
Okay.
so we've gotten an improvement even since then. But we're asking every year one of these reports, and we also want to be careful that while we want to push this, we don't want to make it punitive. There are partners in this, so when there's less consequences, then sometimes the words have a little less teeth. But we want to move this along on several policy levers, the accreditation bodies being the other one.
Right. No, it's like I said, I believe that these MAT providers are the nexus of the syndemic, and I want to figure out all the ways that we possibly can help support them to do what we want them to do and what we need to do to have community level impact. Now, last but not least, our special guest, the reason we're all here today, the writer, well, I guess we'll just stop there. The writer, you get an executive producer credit too. But Beth Macy, I mean, I think the work that you're doing to bring what I think is a highlight to the region. And like I told you, the words on the page, and whoever the cinematographer is, send him a box of cookies, because he also, or she, I don't know if it was he or she, captured what like I say, the heaviness, the malaise, the sense that can lay over Appalachia sometimes. And so you did it on the page, you did it with the cinematography. I want to thank you. You are our last words of the day. Thank you for joining us. Thank you for taking 90 minutes out of your day, which I know is crazy. But thank you for taking the time out to speak with us, to hear and let us hear from you, and to learn a bit about what's going on with us in West Virginia and our little part of the world.
Oh, I loved it. And what great company I was in. I love the idea, Matthew, of using those pharma swag techniques to get doctors to be more open to screening. And, we're still producing young doctors that don't know how to screen for OUD or how to treat a disease that killed 100,000 people in the last year. I just want to close with, I was interviewing Dr. Ingvild Olsen recently. I think she's now with SAMHSA, right?
Mm-hmm.
Yeah. What a corker. She's awesome. She was quoting the study of drug users. Their three top goals are: 1, these are in order, staying alive; 2, reducing harmful substance use; and 3, improving mental health. And what Ingvild pointed out to me, she said, in nowhere in those top 3 were stop using drugs. And a lot of our treatment regimens are still all about that. And I think the idea is we have to meet them. The needle can be the carrot. I know it sounds counterintuitive, but I've seen it work over and over. And so, Dr. Jim, I know you're trying to move the needle on the needles. I think that's really the way to reach this population that doesn't think it wants to be reached because of past bad experience. And really appreciate Toni, everybody who showed up, everybody who watched the show and read the book, and everybody who's working and caring about this issue. Danny was fantastic. I just really appreciate y'all having us.
Thanks. And I want to thank you all for taking time out. And, Dr. Matt, I know, you could only join us for a small piece of the time, but I would like to thank Dr. Ware on our team who came up with this idea and said, hey, this is what we should do. Lee, Brandon for actually making this happen, and the rest of the CEG team for, really pulling this all together, because without them, I just usually sit in my house and do nothing. So again, I want to thank you, Dr. Jim. Thank you, because this was I know we got you last minute, but you always come through on behalf of the community. So thank you very much. Dr. Matt, thank you. And Beth, keep writing. And when the other book comes out, I hope you'll come back and join us.
I'd love to.
All right. And so again, thank you, everybody. Thank you so much for taking the time out of your day. And have a great weekend. We're supposed to get 18 inches of snow up here in Hardy County.
Ooh.
Who's coming to visit or shovel?
We got to go buy our milk and bread right now.
All right, everybody. Have a great weekend. And again, thank you. Thank you for everybody that joined on Facebook and on Instagram. And thanks to my team that pulled this all together. Oh, I got to say, thanks, Ty, who helped us figure this all out. Thanks.
Take care.
Thank you.